Good morning, everyone, and I'll be talking on certain controversies in case selection, and I have no financial interest to disclose. In today's world, every refractive surgeon has a wide variety of options, be it PRK, LASIK, SMILE, ICL, a combination of these treatments, combining these treatments with cross-linking, giving us multiple options in our armamentarium. So what are the key parameters which we need to look into before we select a case and choose a particular procedure for that patient? Most importantly, the age of the patient, the spherical equivalent, important topographic parameters like the steepness or the flatness of the keratometry, the pachymetry, the residual pachymetry, and of course, most importantly, the ectasia indicis, which is being given to us by the modern day tomographers. So I shall take you all through a series of examples where I shall discuss the controversies in each individual case and probably suggest what option we could have done and what we have done and what has resulted in those particular cases. Going ahead with the initial case where we had a thin pachymetry to begin with, a patient with a 4.5 diopter sphere, but a pachymetry of only about 440 in both eyes. Now, as you know, with a pachymetry of 440, no form of keratorefractive procedure or keratoablative procedure is safe. So what are the accepted cutoffs? Minimal cutoffs? Yes, there are still some gray areas, possibly 470 microns for PRK and a 490 for LASIK. But in a patient with 440 microns, with the advent of ICL and the repeatability and predictability of this procedure improving in all surgeons' hands worldwide, it's definitely the procedure of choice in such a patient. But let us look at another patient who has a pachymetry not as low as 440, but something like 465 in this patient and 460 in the other eye, and a relatively low refractive error of just about 3 and 2.5 diopters each. So what can we do now? In this patient, recently we have started probably still and completely untested and a relatively controversial procedure of PRK extra, wherein we combine the PRK with a half-fluence cross-linking, not the entire 5.4 millijoule energy, but do a 2.7 joules of energy for this treatment. And we end up with a fairly stable and good refractive error. At 6 months, the patient is maintaining 6.6, and even we have 1 year follow-up of multiple patients who have undergone PRK extra and are doing extremely well. But then there are some controversies. How low can we go? In our setup, at least, we make sure that the final residual thickness which we are left with is not below 400 microns. So we are relatively correcting a small refractive error for patients between 450 and 470 microns, combining with this cross-linking treatment. We don't change or tweak the nomograms in any way. So as you know, in cross-linking, standard cross-linking, which does cause a significant amount of flattening over a period of time. So does this PRK extra of a low strength, a rapid cross-linking, can it give rise to an increase in corneal biomechanical strength without compromising on corneal clarity, without causing further flattening, without increasing the haze or scatter? 6 months to 12 months follow-up of multiple studies have shown that it does remain stable, but yes, long-term outcomes still need to be looked into. Moving on to high refractive errors, like a patient with a -9 diopter and a 2.5 cylinder. Now let us look at and pristine Bellin-Ambrosio enhanced ectasia displays. So calculating for this patient, whether we would choose a femtolasic procedure on ICL with a flap of 110 microns and an ablation depth, calculated ablation depth of 115, we are left with a residual bed thickness of 302 microns for this particular patient. So I think most refractive surgeons would be extremely comfortable with going ahead with a femtolasic for such a patient. But then recent data does suggest that another parameter which needs to be looked into is the percentage of tissue alteration, wherein we calculate the flap thickness and the ablation depth, that is the total amount of tissue which has been altered above the residual bed, and compare it as a ratio with the central corneal thickness. A cutoff value of 40% has shown a 97 prevalence rate in previous iatrogenic ectasia cases. This percentage alteration thickness greater than 40% seems to be an even more sensitive indicator than age less than 30 or a residual bed of less than 300 microns, which would, in most refractive surgeons' hands, be a very safe limit to cut off. So in this, going back to our patient, when we calculate the percentage of tissue alteration, it goes up to 43%. So would you still go ahead with femtolasic in this procedure, or possibly is ICL a safer procedure in such a patient? Something which we still have it undecided and still remains a controversy. Moving on to high hyperopia. A patient like this with a +8 diopter sphere and a diopter and a half of cylinder, again with a AC depth of only about 2.4 in each eye, similar high hyperopia in the other eye as well. We all know that LASIK definitely in the long run does not work very well with the high risk of regression, and ICL being the AC depth being less than 2.6, we certainly cannot go ahead with an ICL. So possibly in such a patient, a clear lens extraction is possibly a choice. We did go ahead with the bilateral clear lens extraction. Being a young patient, we went ahead with the Toric Symphony multifocal IOL, and at 9 months post-op, the patient is maintaining 6/6 and 6 and is extremely happy with the quality of vision. So high hyperopia is possibly one particular area where a clear lens extraction with a multifocal IOL might be quite acceptable, and these hyperopic patients generally accept the multifocal lenses much better. Again, a very high refractive error of -20 and in both eyes. For such patients, what options are we left with? Definitely no keratorefractive procedure, and toric ICL remains the power. But herein, there are certain variables. The highest power available, at least with the star ICL today, is only 18 diopters at the spectacle plane. And again, when the powers go so high as in -20 and 21 diopters of error, calculating the exact, getting the refraction absolutely right, again, is a problem. So yes, you can be left behind with a residual refractive error in such patients, but then again, bioptics is an excellent tool in such patients where after an ICL, you can follow it up with a top-up LASIK or a PRK, and these patients do extremely well too. I'll close with this particular case wherein a patient with a 5 diopter sphere and a diopter and a half of cylinder, though the power is not very high, you can clearly see there is a significant amount of inferior-superior steepening and in both eyes, which is there in both eyes, and multiple red flag signs in the Bellin-Ambrosio enhanced ectasia display. Certainly, this patient would qualify under the bracket of a form-thrust keratoconus. So what about using toric ICL in patients with form-thrust keratoconus or even in frank keratoconic eyes? Certainly, age is a factor which we need to look into. This particular patient was 30 years of age, wherein the chances of progression was quite low. But then in a younger patient, you definitely wait to see if there is any stability of the keratoconus. If not, even go ahead, if they have a progressive keratoconus, go ahead with the collagen cross-linking. And then once the keratoconus has been stabilized, ICL is an excellent option for these patients. It definitely works better in centered cones. If we do have a decentered cone, possibly going ahead with an Intax and getting a cone fairly better centered and then going ahead with the ICL would be a far better option. Thank you.